Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's October 2025 issue. There are 3 articles that have been selected as our Editor's Choice or Highlights articles this month. The Editor's Choice this month is an original article entitled Blood Pressure Thresholds for Hypertension in Pregnancy and Future Cardiovascular Risk. It is authored by Dr. Andrea Qatar and colleagues from Mayo Clinic in Rochester, Minnesota. Occurring in some 15% of pregnancies, hypertensive disorders of pregnancy may impair maternal and fetal outcomes. Besides short-term effects, hypertensive pregnancy disorders may increase the risk of cardiovascular disease in future years. Hypertensive pregnancy disorders include, among others, gestational hypertension and preeclampsia, often attended by proteinuria, both of which generally start after 20 weeks of pregnancy. Preeclampsia includes preterm preeclampsia and term preeclampsia, the former occurring before 37 weeks of gestation and posing greater risks. Findings from the SPRING trial led the American College of Cardiology and the American Heart Association in 2017 to recommend 130/80, not 140/90, as the threshold for diagnosing hypertension, as outcomes improve in non-pregnant adults when blood pressure is lowered to this threshold. However, the American College of Obstetricians and Gynecologists advocates a threshold of 140/90 for diagnosing hypertensive pregnancy disorders. The study of Qatar et al. Examined the impact of this lower threshold compared with a higher threshold in the diagnosis of hypertensive pregnancy disorders and the risk of future cardiovascular diseases. These investigators used a well-characterized population cohort based on the Rochester Epidemiology Project, and hypertensive pregnancy disorders were defined using an established electronic algorithm with the follow-up extending to almost 19 years. The association between these diseases was evaluated after adjusting for risk factors for cardiovascular disease at age 45, the age signifying the end of reproductive years, and after age 45, as well as the age of first pregnancy and parity. At the lower threshold of 130/80, the percentage of women diagnosed as having hypertension, not unexpectedly, increased from 15% to 44%, and this largely reflected gestational hypertension and to a lesser extent chronic hypertension. The rate of preterm preeclampsia was minimally increased, 1.7% versus 1.5%. After adjusting for age at pregnancy, parity, body mass index, and risk factors after age 45 years, preterm preeclampsia and term eclampsia were both associated with an increased risk of cardiovascular diseases using thresholds either 140/90 or 130/80. The strength of the association was relatively uninfluenced by the employed blood pressure threshold. Qatar et al. Persuasively conclude that a case cannot be inarguably made at the present time to adopt this lower blood pressure threshold in diagnosing hypertension in pregnancy because of the following considerations. Long-term cardiovascular disease risk prediction is not significantly altered by the lower threshold. The rate of preterm preeclampsia is little increased by this lower blood pressure threshold. The short-term effects on the mother and fetus need to be resolved. The therapeutic implications in the management of the hypertensive pregnant patient needs to be addressed, and the societal ramifications of diagnosing hypertension in some 50% of pregnancies require careful consideration. An inescapable implication of the present findings is that even relatively modest elevations in blood pressure in pregnancy may cast a long shadow of distant, adverse cardiovascular effects, as the predictive effect of this lower blood pressure threshold on long-term adverse cardiovascular effects still prevailed, and indeed was not dissimilar from risks predicted by the higher threshold. In sum, Qatar et al. Are to be commended for undertaking this important and timely analysis that bears so essentially upon current discussions regarding the optimal threshold for blood pressure in diagnosing hypertensive disorders of pregnancy. Our first highlight article this month is an original article entitled Long-Term Outcomes of Hypertension and Antihypertensive Drugs in Healthy Young Adults, a nationwide population-based prospective cohort study in Korea. It is authored by Dr. In Tae Moon from Wijeongbu Yulji Medical Center at the Wijeongbu, Republic of Korea, and colleagues from this university and Hanyang University Medical Center, Hanyang University College of Medicine in Seoul, Republic of Korea. With age, the prevalence of hypertension in women compared with men shows a biphasic relationship. Premenopausal women generally have a lower prevalence of hypertension, and while blood pressure increases with age in both sexes, the prevalence of hypertension in women usually matches men by the age of 60 years and thereafter may exceed prevalence in men. This propensity for lower blood pressure in premenopausal women is shown in the present study by Moon et al., which examined hypertension and cardiovascular disease in more than 4 million young adults in South Korea, who were classified as having either optimal blood pressure, normal blood pressure, high normal blood pressure, and hypertension. The essential findings of Moon et al. Were that incident cardiovascular disease significantly associated with hypertension, and treatment of hypertension decreased the incidence by 70%. Notably, hypertension was present in 18.5% of men, but only 5.4% of women. As shown by abundant literature, such lower prevalence of hypertension in premenopausal women largely reflects the effects of estrogens. Estrogen augments the production of nitric oxide and other vasodilators and decreases the effects of several vasoconstrictors. With menopause comes the loss of estrogens and its offsetting vasodilator effects. The pressor effects of increased salt sensitivity and the propensity towards vascular stiffness, known to occur in women, thus predominate. Hypertension in older women thus ensues. Interestingly, in the study of Moon et al., the hazard ratio for cardiovascular disease with hypertension was comparable in young men and young women. This is reflective of another significant facet of cardiovascular disease outcomes with hypertension in young premenopausal women. While less disposed to hypertension, women who develop hypertension may exhibit comparable or worse cardiovascular disease outcomes compared with men. Our second highlight article this month is an original article entitled Association of Hysterectomy with Hypertension Incidence in Korean Women, a nationwide cohort study. It is authored by Dr. Jin Sung-yuk from the Department of Obstetrics and Gynecology at Sanji-Paek Hospital, Inji University College of Medicine in Seoul, Republic of Korea, and colleagues from Inji University College of Medicine and Yonsei University College of Medicine, Seoul, Republic of Korea. Using the database of the Korean National Health Insurance Service, Yuk et al. Evaluated the incidence of hypertension following hysterectomy in women aged 40 to 59 years. 13,650 pairs of women in the hysterectomy and non-hysterectomy groups were matched with a 1-to-1 propensity score, with almost 11 years of follow-up. Regardless of age, the hysterectomy group had a higher incidence of hypertension than the non-hysterectomy group. An increased incidence of hypertension was also observed in women who underwent hysterectomy with ovarian preservation. To account for this finding, the authors hypothesized that following hysterectomy and loss of menstruation, the hematocrit would increase. A higher hematocrit would increase blood viscosity, thereby predisposing towards hypertension. Indeed, the incidence of hypertension was greater after hysterectomy in those individuals in whom the hemoglobin levels increased by 2 grams per deciliter or more. Another consideration may involve reduced levels of estrogens. The subgroup analysis in patients who underwent ovarian preservation would argue against a deficiency of estrogens as a cause for increased incidence of hypertension. However, it may be noted that even in individuals undergoing ovarian preservation, estrogen levels may decrease, and this may be relevant to the increased incidence of hypertension after hysterectomy. The findings of Uke et al. Are significant for several reasons. First, hypertension is a major risk factor for cardiovascular disease, and studies using the Rochester Epidemiology Project demonstrate that cardiovascular and metabolic morbidity occurs after hysterectomy, even in individuals who underwent ovarian conservation. Second, senescence may be accelerated after hysterectomy. It is possible that the increased incidence of hypertension observed by Uke et al. May be the prelude to accelerated aging. Third, the findings of Uke et al. Underscore the risk of hypertension after hysterectomy, and cognizance of this risk would aid in the expeditious treatment of a major risk factor for cardiovascular diseases. Earlier this year, the in-depth review by Novak et al. In Mayo Clinic Proceedings comprehensively discussed hypertension management in women during each phase of a woman's life cycle, emphasizing the importance of a multidisciplinary approach. This review may be regarded as an overarching framework for the specific settings of women's health and hypertension highlighted in this editorial. This topic is of special importance, as women are often underrepresented in clinical trials of hypertension, less often receive standards of care in the management of cardiovascular and other diseases, and often exhibit different responses and outcomes when they develop hypertension and cardiovascular diseases. You can access these highlights and editor's choice articles free of charge during the entire month of October. We invite you to visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you'll find our online-only features and many news stories posted in the News from the Editor carousel on our website homepage based on articles published in Mayo Clinic Proceedings. You will see other free content as well as articles published online in press. You will also find links to our social media by clicking the contact link in the gray bar at the top of the homepage drop-down menu to follow us on YouTube, Facebook, and X. Our YouTube channel you will find full-length author interviews called Insights and our MCP 60-second video article synopses. Our latest Pioneers and Legends feature is an interview with Dr. Veronique Roger, hosted by Dr. Scott Wright. Our homepage includes a collection of articles that honor the past and look to the future in anticipation of our upcoming 2026 centennial celebration. Our website also includes our Mayo Clinic Proceedings issue summary and Author Insight podcast recordings, which are also available through iTunes. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.